Well, first of all, she does have coronary artery disease, meaning she has blockages, but they're not severe. Not only that, her coronary arteries are very calcified, um, but that's not what gave her the heart attack. What gave her the heart attack is, we call it a stress cardiomyopathy. It happened predominantly in women. And is, okay, it seemed like it happens more in women that are predisposed for it, but um, um, it is basically a massive release of adrenaline, let's put it that way, under a stressful situation, meaning it could be bad news, it could be the stress of a surgery, and out of the blue sky, you release massive amount of adrenaline in the heart. And a lot of adrenaline in the heart can trigger damage to the heart. The damage can be permanent, but you can recover with medication. Okay? We normally quote the 30-30-30 rule. 30% chance that it will get better, 30% chance that it will remain the same, 30% that it will get worse. With medication, that's actually not the case. You have, is kind of like the opposite. You have about 60% chance that you either stay the same or recover, and you have about 30% or 30 to 40% chance that you get worse. You normally use medications to improve the heart, but those medications tend to lower blood pressure. So, so the limit as to how much we can give her medications to improve her heart is going to be depending on what her blood pressure does. So that's the only downside to this. I'm encouraged by the fact that the amount of cardiac enzymes released in the bloodstream was small, relatively speaking. If you look at her heart, it's pumping 35%, it should be 51 to 69%.
Right.
And that's normally what we see with a massive heart attack. And I know that her heart function was normal because she had an echo a few years back that was normal.
She was just at Scott and White a month ago, and they ran her whole. She was just at Scott and White a month ago, and they ran her whole body up and down, and she didn't have anything. Then she was stomach pain. She was there for a week, and so they did everything on her, and she didn't have anything. And
yeah. And so, but the amount of cardiac enzymes released was small. So I don't think that the damage is permanent. So I think that mostly what she has is that the heart muscle is stunned.
And what is it doing? Like the heart muscle?
Let me finish the thought. And so what does that mean to be stunned? If I grab a bat and I hit your thigh, you're not going to be able to walk well because of pain, but because you bruise the leg.
Mm-hmm.
But you'll recover. It's not like we're going to have to amputate your leg because of that, or that your leg is never going to work again. Okay. So I think that that's what I mean by that is that I think that because there was not so much cardiac enzyme release, that means that there is not a lot of dead tissue, and that tends to predict that she'll recover.
Mm-hmm.
Once you have this condition, the chances that could happen again are not small. We're still learning about this condition, almost to the point that most of the knowledge about what this condition is comes from the studies done in the last 5 years. And what they say is that it's not a one-time deal. This can happen. But based on my knowledge, people that have a low threshold to pain
That's not her.
have a higher incidence of developing that. And I don't know her well, but all I can see is I see screws on her back when I'm doing my procedure. She has a stimulator in her back, and the surgery was done because the pain on the shoulder was so bad that
Her stimulator's turned off. Her stimulator's turned off because it didn't work. So they didn't take it out, they just turned it off.
I hear you, and that tells you that basically somebody has been desperate to help
Oh, yes.
for pain.
For the past 20 years.
And when you have that much pain, it's not that you're imagining it, but your brain has a lower level to feel pain that is worse than it actually should be because, well, the neurochemistry of the brain allows that to happen. What exactly was the trigger? I'm not going to jump to tell you exactly what happened. What I can tell you, based on what I know, it doesn't seem like it happened during surgery because she was fairly stable.
It took about 5 hours to get her out of recovery. And when she came out of recovery, her anesthesiologist told me that she gave her a shot of Narcan to wake her up. And that is pure
of what?
Narcan, which is pure adrenaline. Pretty
Well,
much.
no.
Well,
it is. You could. Okay, so no. So Narcan blocks your pain control pathways. Okay, and can trigger a hyper response of adrenaline.
right.
And so it's a
The pulmonary edema, which she had, and a heart attack, which she had.
in other words, the pulmonary edema was consequence of the damage to the heart, and the damage to the heart happened to the excessive release of adrenaline. Was she chronically on narcotics?
Yes, since like the back surgeries, when her spine compressed nerves and caused her to have a migraine for years. That's where all the surgeries came from, trying to fix that. And so from that point, with her arthritis breaking down her body, she does take a couple pills a day. She's been taking more because of the shoulder. She used them all up, but she's very careful with them because she's old. She's like, oh, I don't want to, and she keeps up with it. But she's definitely a pain clinic too.
So the Narcan could have played a role. Is not really being described, but theoretically,
yeah,
it could be a triggering factor or an exacerbating factor.
What were you thinking it was before that? What were you thinking it was before that? You said it didn't happen in surgery.
And it didn't happen in surgery based on the sequence of events. I mean,
because he came out and said everything went fine. She was doing good. Took it easy.
I know. And so this was a pretty large hit, and so she would have crashed during surgery or immediately after surgery if. This doesn't go unnoticed.
The heart attack would have been noticed during that.
Exactly. And so I think
I just knew
that it was related to something else happening. I'll tell you, if I certainly would know. I mean, if I knew, I wouldn't be giving you mixed signals. I don't know. I haven't really sit down to look at what else could be pinpoint on these circumstances. I guess that I can go through the records and look at that.
Yeah.
And you said she had some blockage?
Yeah, there is some degree of blockage
That caused a heart attack?
in all three arteries. The worst blockage is about 50%, but nothing.
Didn't require a stent.
No, for sure.
No.
So she needs nothing but medicine?
She needs nothing but medicine. Yeah.
Just to try
And the
to-
problem is going to be, I'm going to be limited because there's so much I can let the blood pressure go lower. And so I'm going to try to titrate the maximum dose of medication that I can give her. And time will tell. And so the typical thing that we do is that in 3 months we repeat an ultrasound of the heart to see how much recovery took place. If her heart has not recovered enough, that she would need a pacemaker defibrillator, basically. We'll decide then. My hope is that based on the information I have at hand, that she'll recover enough heart function. That's my hope. But an ultrasound in 3 months is what it's going to tell us.
So the chance of her having another heart attack?
30%.
Once it happens once, it can happen again. And so because that means that she does have the capability of trigger massive. I mean, normally what we believe it is in good part it may be related to spasm of the arteries, sometime inside the tissue, rather than in the arteries you see with the naked eye.
They had said that.
And that means that. And that can be triggered by a massive response of the nervous system to the heart that makes those arteries go into spasm. And at least that's one of the theories. I mean, nothing is conclusive with this syndrome as to what really happened. But we know that it's adrenaline related, let's say that.
What do I do at this point on?
Medicine.
So we'll be titrating that. We're going to titrate that as we go along to see how much she can tolerate that won't drop her blood pressure too much. So what we normally will do is that we'll let her recover from my procedure.
And she's got to be on her back now for the next 6 hours. Is that correct?
I put a plug.
You put a plug, 2 hours?
Yeah, a couple of hours.
Okay.
She can go home?
No. She can sit up.
I need to titrate them. See,
Oh, you need
if
to
her blood pressure was high, let me start with this and call me in a few days and I'll increase it some more. I need to figure out to be able to give her something that is not going to give her hypotension at home.
Yes.
And then she's going to dump in the ER without,
Well, we
So
live 20 minutes away from an ER, so
I know, but
she would not end up in an ER.
But we'll try to figure out something quick so she can be home, hopefully in the next 24 hours or so. Okay?
Okay.
Thank you.
You're welcome.
That sounds like good news to me, because if we wouldn't have known what was going on anyway, the prognosis of her going back to what she was before sounds like it would be what she was at before. I mean, right?
No,
Is it,
because he didn't even talk about the heart damage. He just said, well, she didn't have enough blockage to do a stent. She's got some calcification, but nothing that caused a heart attack. I've got it recorded, the first 4 sentences out of his mouth where she didn't have enough to stent. She didn't have enough blockage to cause a heart attack. And then he just kept going on and on about what else could have been. Well, it was adrenaline. Well,
but he said it was like a stress thing that happened.
and he's also
So
said
that could have been a
it
stress thing.
very well could have been the Narcan.
That's what I'm saying. That could have been a stress thing.
I cannot believe it.
He said adrenaline.
So all night long, she was having, I guarantee you all night long, Amanda, she was having that heart attack. I kept hearing her all night long. And it would go dink. Because they weren't monitoring her. And they should have been.
Then ask them why.
I'm
Go
going
ask
to.
them,
And
why
I
wasn't
have.
she monitored?
I have.
What did they say?
They just, we don't know, really. They don't know. They don't know.
I mean, it's good
They don't
that
know.
she's got this medicine, but now it's there.
But with
Yeah.
the,
So the chances of anything happening
No stint.
much more than they were.
No sense.
Just medication.
golly. I just think she's so sweet.
Not all of it matters.
I had to go to the restroom. Huh? I don't know.
Well, maybe we'll be home in 24 hours.
Yeah, we'll be home in 24 hours. And that'll be good.
She told you nothing wrong.
I pray that when they do the ultrasound in 3 months, that her heart's back to the same ultrasound status
Yeah,
that
I
it
do
was
too.
before.
That maybe it is stunned and it will knock back, but I'm not saying it wasn't
I
stunned.
feel like they acted so
Why?
fast after the symptoms started that maybe that helped. Not
It
saying
did.
the damage that was done, but like having that immediate
bypass
intervention.
put in place did save her life. And I told him that.
Not
He
save her
goes,
life, but maybe could have saved the increase
the
in damage.
damage, yes. And it probably did.
Yeah.
Glad she went home,
Mm-hmm.
Yeah.
on the way home.
And it probably did. The fast acting did. Because if I'd gone getting a Dr. Pepper at the cafeteria, we'd have a different story because she wasn't being monitored. And I ignored and caught that shit. And so I'm like a little annoyed by it. And y'all can't, you know, I'm just a little annoyed by it. Because she's going home with a
You
broken
have to
heart.
say that wasn't his fault or his doing. So like when you
I
come
needed
at
to
him
ask the
from it,
question.
he feels like,
No, I
why are
needed
you
to ask.
attacking me?
No. He's a doctor.
He's not answering like he's trying to avoid that.
He didn't. In fact, he answered. He said it very well could be
Yes.
that.
He agreed.
He agreed
He's
to
gonna
it.
research, look into it more.
I guess I'll look into it, he said.